All right. Well, why don't I go ahead and get started? Thank you all so much for coming. I'm Christine Mallins, and I'm the director of the Center for Social Science Scholarship. And we're really pleased to have Ian Stockwell here with us. We're going to record this session, so just bear that in mind, and we will make it available on our YouTube channel in a couple days, and you can forward it to anyone else who might be interested. Ian is the Senior Director of Analytics and Research and the Chief Data Scientist at the Hilltop Institute at UMBC. He's also an adjunct professor in the Erickson School of Aging Studies and affiliate associate professor in UMBC's Department of Information Systems. He's going to talk today about better health through data, drawing on the resources of the Hilltop Institute. So Ian, I will turn it over to you.
Great, thanks, Christine. And can everyone hear me okay and see the slides? Good. All right. So thanks, absolutely, Christine, for having me, and I really appreciate the time. It looks like a fairly small group today, so I'm happy to go off script. I can run through the slides and just spout if that is what people prefer. But if you have questions or interjections, want to take the conversation in a different direction, I think we're a small enough group that we can handle that. And I don't know what is most interesting to you folks, so I would appreciate the guidance as we go along. Okay, so today I'm going to talk about better health through data, and that is, I think, a very apt title because of where I work, the Hilltop Institute at UMBC, and what Hilltop is. And it's interesting, the more and more I talk to faculty around campus, there are quite a few faculty that don't really know what Hilltop is, even though we're like 50 people and we bring in $10, $12 million a year. And even those that have heard of Hilltop, I think are not quite sure like what box to put us in. Because we are kind of a unique organization, not just unique within UMBC, but as we have learned, as we've talked to other states and other universities that do health policy and health data analytics, we're kind of unique nationally. There are a few other universities that have organizations like Hilltop embedded within them that serve as kind of health operations researchers within state departments of health, but UMBC and Hilltop it's really, we're like at the pinnacle of that type of relationship, and it's great. Anyway, our mission. This is our mission. This is what we try to do, and the reason that mission is so central and that we took so much time crafting that is because we have all of these capacities within staff at Hilltop, and this is the orange box. And we have these kind of broad goals, right? Our goal is to help people live healthier lives, and yet we want to do that through very distinct groups of work. Research and engaged scholarship is one, reaching a national audience, so the dissemination of our work that is done at the state level more nationally, but all coming back to service to the state, right? So I often tell people that we're a university research center that doesn't actually do a lot of research. Most of our budget comes from interagency agreements with state agencies. So, we work more like a boutique contracting agency than a university research center. Now that's changing. We're becoming more involved on the research side of things. Part of my job is making sure that we get research proposals out the door, both in conjunction with other partners around UMBC, as well as other partners with other institutions, and solo, right? Like we have 50 staff, we're up to like 8 PhDs. So we should and we are now kind of pursuing research for research's sake, as long as it comes back and helps us with our mission, right? What we don't want to do is do research for the sake of publication. We want to do research that may lead to publication, but more importantly, answers a question that we can then use that answer to serve the state of Maryland and beneficiaries with it. So Hilltop has always been, for the 30 years we've been around, data rich, which is a nice place to be, especially because I'm a data person. And what I try to do in this slide is kind of categorize our major data sources into a few buckets. And at least this is the way I think of them, right? So at the top, we have administrative data. So that is data that most health services researchers are familiar with in the form of claims or encounters, which are just claims for managed care organizations, eligibility, enrollment files, demographic files, that sort of thing. And we have those data, and this is important and still kind of mind-blowing, for everyone in Maryland Medicaid going back years, and everyone in Maryland Medicare going back probably 10. We do have access to the commercial data that is not as clean and it is not individually identifiable, where our Medicaid and Medicare data are individually identifiable. And it's a not quite real-time cadence for updates, but pretty close. So we actually get monthly loads for both our Medicaid and Medicare data. And it allows us to do a lot of stuff. And again, coming back to like why the Hilltop's unique role in Maryland, that type of longitudinal access and that frequency of update is important because again, we do like healthcare operations primarily. But not only is that important with healthcare operations, but it allows us to do types of quote unquote research activities that in these yearly RIFs, but research identifiable files that are available through other data sources may not allow you to do. We also have access and stored in-house clinical, functional, and social data. These are for different types of assessments, specifically for long-term care population. We often build and deploy surveys for different state agencies. We've gotten information on non-medical supports, nutrition assistance, and energy assistance being two. We're also in the process of working with National Institute of Aging to do some data linkage work for their handle study. So this is a very long-term longitudinal survey for individuals in Baltimore City, where there's just a host of different clinical and cognitive and social and physiological information that's being collected on survey respondents, and we're going to match those to above the Medicaid administrative data that we have at Hilltop. We have a ton of data from the hospitals, all payer discharge. This is a big one, as well as community benefit information. The hospitals in Maryland are all nonprofit, and so they have to defend that nonprofit status. And we have a bunch of information on how they do that, what community services they offer that qualify them as nonprofits. We also have financial information from the managed care organizations in Maryland, as well as the nursing homes. So we have all these data, and what do we do? Again, I'm kind of a grouper by nature, so I like to think of these as kind of our core tools in our analytic toolbox. We do a bunch of program evaluation, both ongoing evaluations, as well as kind of big like bolus evaluations. The program is run, and then we evaluate it at the end. And we have expertise with a fair number of more sophisticated multivariate methods to do that type of evaluation. Fairly new to us in the past 4 years or so has been an expanding predictive modeling footprint, and this is what I'm going to talk most about today. We currently have a number of predictive models that are not just developed and published, but actually in production, right? So these are like live models that are ingesting data from different sources, creating risk scores and relative risk rankings and reasons for risk, and sending those out to care coordinators, managed care organizations. They're used to triage waiting lists for services, and they're kind of embedded in the health information ecosystem of the state. More on those later. We also have and developed and host a decision support system for the Department of Health. We have one that is focused on Medicaid and another that's focused on Medicare, two different user sets, but hopefully at some point we'll kind of pull them together. And we do a lot of just other data stuff, right? So for problems that we try to solve that don't fall into one of our top two buckets, just pull out our calculators and go at it and figure it out. I personally like constrained optimization, so linear programming models, because what we see in healthcare domains for sure are these problems where you're trying to maximize the efficiency of a limited resource, have constraints that represent those limitations, and you're trying to optimize within it. LPM models are. Okay, so predictive analytics, this is a hot topic and certainly one of Hilltop's main growth areas. And so I started talking about Hilltop as an organization and what we try to do as an organization. And when we think about how we build and deploy predictive models, kind of come back to this core philosophy. And it starts with there's a lot of waste in healthcare. And not just waste, meaning that there are services that happen that have no clinical value, but waste in that there are services that happen that have clinical value, but didn't need to happen, right? So these are, we'll talk about a number of these. The model that has the largest footprint in Maryland is predicts avoidable hospital events, right? So these are cases when individuals are in the hospital and they're not in the hospital for a bad reason, in that the hospital is doing something for the patient that they should not be doing, but the patient shouldn't need to be there, right? The fact is that hospitalization is an indicator of a breakdown of our primary care system, because, for example, an individual with diabetes should be able to be treated for that diabetes in a primary care setting and not have to go to a hospital, right? So it's a little bit different than in the literature when it's talked about wasteful care or low value care, whatever. It's like these things that happen and never should happen. And this is a little bit different because what we're saying is they happen and they don't happen. It's not that they're happening for a bad reason or that that instance of care does not have value, but that could have been prevented, right? Nobody needs to go to the hospital, or nobody wants to go to the hospital. People that should not have to be in the hospital because the hospital is kind of the standard of care for what a person's going through. We want to identify those and ensure that they get the treatment that they need in a primary care setting, so they don't have to step through those doors. Why is that important? So when we talked about optimization problems, where we have a constraint and we're trying to optimize within a constrained set of resources, to us, predictive modeling is no different, right? If you have a one-to-one assignment of a nurse or a care coordinator to a patient, then it becomes much less relevant. But when you have a primary care physician that has one care coordinator and a 500 patient panel, then it becomes very relevant, right? Because there is no way that primary care provider or their nurse manager or their care coordinator can ensure that all 500 patients on their panel are receiving the care they need in a timely fashion. It's just not possible, right? So then we get to a triage situation where you have a limited number of resources, and you want to assign those resources where they're going to do the most good. And for us, that can be quantified. That is with individuals for whom there is the highest likelihood of the event that they're trying to prevent. And finally, this third bullet, having been in the healthcare sector for a while, primarily the predictive models that you see in industry and even in academia are actuarial risk models, right? They are models that are built and trained to predict the cost of an individual's care. Those models are great for rate setting purposes. And I would argue not much else, right? Because people can be high cost where that cost is associated with a complex standard of care, right? The best standard of care, cancer, kidney failure, things like that. They're just going to be expensive, and that's say okay, right? Like that they are receiving the care that is most appropriate for them. And then there are people that are expensive and don't have to be expensive, right? So people who are bouncing in and out of the ED, people who are in inpatient settings for things like asthma, diabetes, and those don't have to happen, right? So those are cases where an intervention, good intervention, can help divert individuals from those settings. And to us, those definitely aren't the same, right? And we don't want to treat them as the same. We don't want to treat a high cost individual for whom their high cost is necessary the same as a high cost individual for whom that high cost is not necessary. So we very specifically build our models to measure the likelihood of events and not the likelihood of a high cost. So here are a few of our models. These were, this is what happens when you ask like a PhD to name something. I said PRE because it's predict, and then we have acronyms so that we can just keep track of them in a big spreadsheet. PRE-H, again, is our biggest model. This is used in both the Maryland Primary Care Program, which is a Medicare population, as well as Maryland's Medicaid population. Total lives under this model, as of this month, are like 1.8 or 1.9 million people. And this is, again, these are production models, right? So this is in production. We're sending scores through Maryland's Health Information Exchange to care coordinators for MDPCP, and we're sending the scores directly to the managed care organizations and Medicaid. Pre-AI is our nursing home admission model. So this is currently used to prioritize access to Maryland's home and community-based services waiver. So this is an interesting one because, talking of scarce resources, there are many more people who have applied to access home and community-based services in Maryland than the state has spots available for. What used to happen was that individuals who were able to wait the longest were the ones who got access to these services, which is kind of counterintuitive, right? Because if you have services that are meant to keep people out of nursing homes and you give those services to the people who were able to stay out of nursing homes the longest, it's kind of a weird incentive and you're probably serving the wrong people. So what we've done 3 years ago now is shift from prioritizing individuals who were able to wait the longest to individuals who are at the highest risk of what those services are trying to avoid, which is a long-term nursing home. We also have a COVID-19 hospitalization model that is deployed within the Medicaid population. We have a model that we developed for hospital readmissions in the commercial space. This is interesting because it is not deployed. We developed it with research funds from the Robert Wood Johnson Foundation. and have never really quite found a home for it. So hopefully it will go into production somewhere at some point, but this is one that just lives on paper and in our hard drives for now. We're also working on other models. Three that are outlined here: hospice, opioids, and diabetes are specific to the Medicare population. We've had conversations with Medicaid managed care organizations on doing models for birth outcomes, birth weight, postnatal follow-up appointments, stuff like that, as well as some given disease models, but those are just in discussion right now. So this is, it's kind of a mess of logos, but hopefully it's easy enough to follow. When I say that these models are in production, that's not to say that we have packaged up our score code into nice little packets and we kind of ship them out, or we put them up in GitLab and people just kind of plug into them as necessary. The way that information by and large moves within our healthcare ecosystem, it doesn't look, in a lot of cases, doesn't look that different than it did 10 or 20 years ago, right? So we still at Hilltop are ingesting a lot of data. Here the sources are seen here: OHCQ, Maryland Department of Health, and CMS. And we in-house are running through our production framework, which I'll share a little bit later, and then outputting those scores to different user interfaces. So CRISP is one, and that serves the MDPCP population. And LTSS Maryland is another. This is for the long-term care and home and community-based services for Medicaid, and then directly to Health Choice MCOs serving the Medicaid population as well. So this is, for those of you who are data savvy and modelers or in the healthcare system, a lot of the work, like the effort that we at Hilltop put into these types of models, a lot of it is on model development and training and making sure our covariates are right. But a lot of it is this like nuts and bolts, moving data from one place, ingesting data from one place, adding value to it, and then outputting it to another place. And I cannot overstate how difficult and complicated that is. It is one thing to make a model, it is another thing to have it in a production environment. Okay, so I'll talk a little bit more about kind of our flagship model, Pre-H. As I said, it's in deployment status for 2 populations. And it's important to think about like how different those populations are. Right, one is for 400,000 Medicare beneficiaries. So these are primarily individuals over the age of 65 with a smattering of younger disabled folks in there too. So that's one cohort, right? And then another cohort is the Maryland's Medicaid population. By and large, moms and kids, but there are childless adults in there too. And just conceptually, right, these are 2 very different groups of people. And yet we wanted to predict the same events, same types of events, right, avoidable hospital events, both groups. And so what we did was actually built a single predictive model, or a single predictive modeling approach or architecture, I guess, that can be trained separately on each of these populations. And so we have a Medicare version of the model that we have trained with Medicare utilization data, and that we use to score new Medicare beneficiaries, or Medicare beneficiaries that are within the program, and we have a new month of information. And we have a parallel model architecture that sits on top of the Medicaid population, and that's trained using Medicaid utilization, and then is used to score those Medicaid participants. And it has been quite interesting being part of this process, just how different those models are, right? So the primary risk drivers between the two populations are similar in that they're mostly like chronic conditions, but they're different chronic conditions, and the weights on each of those chronic conditions are quite different. There are some, specifically in the Medicaid population, where environmental risk factors are significantly more impactful than in the Medicare population. There are different types of events, right? So an avoidable hospital event has these condition criteria. Certain of those are more prevalent in one of the populations than the other. And yet, core to our kind of production approach is that we want to take the same, it's the math isn't different, right? The structure, the way the model works is the same across both populations, but we do want that model kind of react differently between the two populations because they are so different, and that's shown to be true. And so because we focus so much on event prediction models, and because one of our core philosophies is that event prediction is much more relevant for triaging scarce healthcare resources than actuarial risk, we want to make sure that we define our events, right? The Y variable in our algorithm, to be as reflective of the types of things that a good healthcare intervention can change as possible. So for pre-AH, and I won't go through this for each of the models, but I think pre-AH is a good example. Our definition of avoidable hospital events matches what AHRQ has defined as PQI, right? And so these are hospital events that fall within the 16 chronic and acute causes hospitalization. Some of them, for example, are asthma, diabetes, UTI is in there, dehydration was in there, but it dropped. A couple other, or a number of others. But again, this core concept that these are what's known as ambulatory care sensitive conditions, right? So a place or an event where a good primary care intervention can divert the individual's need for hospital service, right? So that is core. And so next I'll talk a little bit about like how we did it, and I think the model development looks probably very close to what one would do if they were pursuing this purely for research. We looked at literature, right? We pulled a whole bunch of articles, and what we were looking for is cases where within the literature existed known risk factors, and we weren't that picky about the population. We wanted, by and large, a publicly funded population, not necessarily commercial, although if there was a good risk factor that was found in the commercial population, But what we didn't want to do was take kind of this machine learning approach where you take all your data and you just kind of dump it into the algorithms and you let the algorithms do it. Because remember, with a production algorithm, you're going to have stakeholders in that production process. So I knew that I had to go into meetings with the primary care practices and with the Department of Health and with CMS and explain not just how the model works, but why we built it the way we did. And what I was not willing to do was to go there and say, oh, well, we took all of these claims data and we dumped it through TensorFlow or whatever, and poof, out popped the model. Because no one would trust that. I wouldn't trust that. But what I could say was we read a whole bunch of articles and we found this set of risk factors, right? Socio-demographic risk factors, environmental risk factors, condition-based risk factors, utilization risk factors, pharmaceutical risk factors. And we coded those, right? So we identified people that had diabetes. We identified people who had heart failure. We identified people's continuity of care. Like we built a metric for how centralized their care was or how dispersed their care was. We built all of these environmental risk factors based on the address of the beneficiaries. We pulled risky pharmaceuticals and we set flags for those. And so what we had were this collection of covariates or risk factors or features that had value in and of themselves. Right? We could say how many people had diabetes. We could say what the average level of care continuity was. We could say all of these things, and those became the covariates for our model. So this is the model. I'm not going to spend too much time on it, but I included it just for folks who cared. It's basically a fancy logit. We have compared, we benchmarked this type of model to random forests and to RNNs. We have actually run it through TensorFlow as well. And this is heresy, I guess, but a good linear multivariate model is just as good with respect to predictive power as a fancier method. And that's what we have found. We have found it over and over again. Every time we build a new model, we go through this thing where we say, okay, well, how does a neural network do when compared to logit? And we have never had a case where one of those other methods has significantly outperformed our logit model. So we stick with logit. It's easy to build. It's easy to train. Easy to explain. That's probably the most important part. And we're going to keep using it until we find a better method. So this is what we do every month. Again, this is not like we post our score code to GitHub and then everyone kind of reaches in and grabs it. This is a very data flow intensive process where every month we get new data from our Medicare and Medicaid data sources. We push those data through a whole bunch of integrity and validity checks. We do our pre-processing, which builds our analytic data set, assigns our features. We score everyone in our cohort. Every month within the COVID pandemic period, we have also retrained our model. We have been doing quarterly retrainings pre-pandemic, and then utilization went so out of whack during the pandemic that we wanted to train to stay up to date. Hopefully we'll go back to quarterly soon. And we take those scores and push them out. Right? Data goes out the door, and what those data look like are one record per person with an identifier for the person, a risk score, which is likelihood of an individual experiencing whatever event we're modeling, and then all of their what we call reasons for risk, right? So these are the covariates that were flagged as, yes, this is relevant to the person, and then their contribution, each of those reasons for risk, contribution to the overall risk score, and then a kind of a text explainer of why that reason for risk is important. And so those data go into UIs like this, where you can pull up a person, on Ian, and say Ian has a likelihood of avoidable hospital event of 16%, and this is why. These are, a donut of each of the risk factor domains and their relevance to that overall risk score. List out each of the conditions. What we've heard from users is that this is super helpful because it stops them from having to dig through charts, even if they just want kind of a snapshot of the person, and then they can use this to think, okay, well, look at this. Half of my risk is for conditions, and that condition is COPD, and so I need to make sure that Ian COPD is managed. Let's do medication reconciliation or whatever. Yep. Okay. So also key to that production process is ensuring that the models that we have are doing what they're supposed to do, right? We call these predictive models, and they better be predicting what they're supposed to be predicting, and predicting better than any other alternative that's out there. And what we found, time and time again, is that they do, and by and large, like, that's easily measurable, right? So we can look at how our predictions scored with respect to a holdout group, where we take 80% of the data that we have and we train the model, and we apply that model to the 20% that we didn't train the model on, and see how well our predictions did to what actually happened in the group. So that's holdout validation. We also do temporal validation, right, where we deploy a set of risk scores for 1 month, say January of 2021. Then come July of 2021, we go back to January and we look at our data and say, okay, we know what risk we assigned to people in January. And then now we know what actually happened in January. So let's compare those two and see how we did. So these are concentration curves showing our predictive performance. And as you can see, it's pretty good. So if you look, you guys can see my cursor, but along the horizontal axis, if you look at that first block of people, so 0 to 10, this is our the top 10% riskiest people as assigned by their our likelihood score. And the vertical axis is the proportion of avoidable hospital events that occur within that segment of the population. Okay, so if you look at the top 10%, what you'll see is for our Medicare model, we capture about half of all avoidable hospital events within the top 10% riskiest people when ranked by our model. We capture about 55% of those for the Medicaid model. And so this is the way that I think is most helpful in doing validation, because it ties so well with what we're trying to do, right? The whole premise of this is that there are providers and care coordinators out there who don't have enough time to touch all of their patients. So what we want to give to them is a way to prioritize their patient roster so that they can spend their time on people with the highest risk of having an event that they can help avoid. So when I show this to providers and practices, they can look at this and say, okay, this makes sense. So if I have enough time that I can hit the top 5%, right? If I can talk to 5% of my panel in a month, then I'll hit a third of people on average that are going to have an avoidable hospital event. If I can do 10%, that's even better. If I can only do 1%, that's okay, because I'm still going to get way more than 1% of people who are going to have that avoidable hospital. All right. So we have a ton of work in the pipeline. One of the biggest kind of pushbacks that I get when I talk about our models is, oh, well, administrative data is great, but you're not getting anything from the EHR. And my response is, that's absolutely right. And yet our model still performs as good or maybe a little bit better than models that live within the EHRs do. And what I personally and what I think we as a group want to do is build models that do both, right? So we have kind of the power and flexibility of these longitudinal administrative data sets where we get data from all different types of providers, right? They don't have to be within the same hospital. They don't have to be within the same system. For individuals who have utilization that's spread out geographically, we can base our models off of all of that utilization and all the information for people. And wouldn't it be nice if we could augment that with data from the point of care, right? So with data from a functional assessment or data from an EHR where a person is newly hospitalized and there's no way that that claim for that hospitalization is going to get into our model by the time they're discharged. And so we have two proposals that are going in shortly that try to tackle that, right? So how can we augment our administrative data with data from other data sources so that we're not losing this good predictive power that we have based on those data, and yet we're not ignoring that there's other data out there that's relevant. Okay, So that was, it felt like a lot. It felt like a lot to me. I'm happy to have a discussion if there are questions or conversation or opportunities for collaboration, whatever the audience would like to. Or I can just talk some more, read some poetry. It doesn't really matter. Okay. Well, I guess if there's no questions, oh, I see something. I'm sorry, disappeared. I think something came from the chat.
Yes, Ian, can you say that? It says, have you tried applying the
Yep.
model other than Medicare or Medicaid data?
Got it. Yep, I got it now. So no, the models. So we have our avoidable hospital events and COVID hospitalization models have been trained on both the Medicare and Medicaid populations, but not the commercial population. Our hospital readmission model has not been trained on the Medicare or Medicaid population, but only on the commercial population. So what we have not done is try to move one of those models, one of the public payer models to the commercial population, or the commercial models to the public payer population. We have not done that. And one of the reasons is one of the issues with commercial data is that we really don't have a good deployment mechanism at Hilltop into commercial payers. So the readmission model that we built on the commercial data is actually not Maryland's commercial data. It was data through the Healthcare Cost Institute, which for those of you who aren't familiar with it and you're interested in having a ton of data to work on, check them out because they are kind of the repository for commercial claims data nationally, and you can get access. It's not cheap, but you know, tens of thousands of dollars, and you can get access to the records of 160 million commercial beneficiaries. It's quite an amazing data source. Happy to answer. Oh, you're welcome. Any other questions that people have? Okay. Well, if anyone thinks of any, here's my information. Don't give me a call because I'm not back in the office yet, but shoot me an email or stop by. We're on the third floor of Sondheim Hall. Also, don't stop by yet because I'm not in the office, but soon I will be on campus every Tuesday. So if it's Tuesday, come on by. I'll be around, or shoot me an email. We'll talk about collaboration, or if you're just interested in the work Hilltop does, I can help with that too.
Thanks very much, Ian. I'll share that contact information when I send out the recording from today's workshop.
Great, thank you.
Okay, thanks everybody for coming today.
All right, take care.
All right, take care. Thanks, Ian.